Hello, sir. Yes.
എല്ലായിടത്തും എല്ലായിടത്തും ഉണ്ട്. ഞാൻ പറഞ്ഞതേ ഉള്ളൂ കടവന്ത്ര. അവിടെ ചെന്ന് കഴിഞ്ഞാൽ അവർ ഈ എൻഡോക്രോളജിക്കാരെ ചെയ്യണത്. ഞാൻ സാധനം കുറിച്ച് കൊടുക്കാറുള്ളത്.
Hello, everyone. Madhusudanan sir is joining in just 2 3 minutes. He's having some technical issues. So let's wait for 5 minutes more.
Okay, am I audible to you? Hello?
Yes, sir. Yes, sir.
Yes, sir.
So, sorry for the delay because I have to, the network is not working in my house. I have to go to my nearby place. So I'll just wait and open my presentation. Okay, I will share my screen now. Can you see my slide?
Not yet, sir.
Oh, yes, sir.
Okay, thank you. So we'll start straight away. Just 1 minute, okay. Now, as usual, I'll start with a very short case first. This is a story of a 57-year-old lady. She noticed bulging of her right eye for the last 3 years. For this complaint, she took treatment from a physician and her symptoms partially improved. Now, for the last 6 months, she noticed recurrence of bulging and diplopia on looking up. No pain in the eye. This is the video of the patient. You can make proptosis in the right eye. Even though she complained of diplopia, there is only mild restriction lateralward, but she complained of diplopia looking up and medially. Now she's telling double. Now also telling double. She's single.
Sir, your video is not playing.
Not playing?
It's playing, sir. It's playing. It's playing.
It's playing.
Okay. Okay, thank you. So actually she has got a proptosis, no obvious restriction, and she complained of diplopia. So it's a short case. What innovation would you like to do in this patient?
Thyroid function test.
Pardon?
Thyroid function.
Yeah, what is only unilateral, and there was some pain also along with it. It could be thyroid, agreed. There is one possibility.
MRI, contrast MRI.
Oh, which part? She's also got a ptosis. Which part will you do? Orbit,
Right,
no?
orbit.
Okay, this is the lateral view. On closing, you can find the proptosis of the right eye. Left eye, there must not have a proptosis. So this is the MRI version. Diplopia looking up, medially downward, mild restriction of abduction. Okay, MR, this orbit. Now, what do you see in the orbit and make a diagnosis? This is on the right side, which you can see there. This is the T1 weighted.
Pseudotumor.
Okay, let's go to right. See, not only on the right side, if you look carefully, see in the middle rectus muscle as well as adjoining the tendinous portion and the scleral area. This also can be seen on both sides, not only the right side, left side also seen on the inferior part. Then
Any contrast film, sir?
I'll show the contrast. This is again another cut. This is a T2 fat set showing the hyperintensity of the lesion bilaterally. This again contrast. Not contrast, T2 fat set. This is a contrast study showing intense enhancement of the lesion. You can make it out there. Now, what is your likely diagnosis in this patient?
Orbital meningioma, sir.
It's like a meningioma. It is an irregular shaped lesion attached to the tendinous ring and the orbital sclera.
Pseudotumor.
Sir, there is tram track sign.
IgG4 related. disease.
No, it's not. The Amtrak sign is not there. No, it's outside the. It's beyond the optic nerve.
Likely inflammatory pseudotumor.
Yeah, that's a good possibility. Inflammatory pseudotumor.
Lymphoma.
Lymphoma. Yeah. Now, the point I would like to mention, if you get any female coming with this kind of orbital lesion, always exclude a carcinoma breast also. That is important. But I agree with your orbital pseudotumor. So the only thing is bilateral. That is not against that possibility can occur. But when you get bilateral lesion, I think lymphoma is another good possibility which you have to keep in mind when there is a bilateral involvement. Okay, so what can be inflammatory pseudotumor, that is IgG4 disease. Sjogren's syndrome you have to keep in mind. That can also produce inflammatory granulomas mimicking inflammatory pseudotumor. Sarcoid is another condition apart from secondaries and lymphoma. So all the investigations were normal. ANA profile normal, CT just normal, serum calcium normal, AS level normal. And this is after 2 weeks, everything subsided. Proptosis subsided, diplopia subsided, and no pain also in this patient. So most likely what is the diagnosis?
Orbital pseudotumor.
And inflammatory pseudotumor. Most likely, nowadays the orbital inflammatory pseudotumor have been renamed as IgG4 disease, which may not be present. Always you may not pick up this IgG4 in the serum or in the CSF. Only tissue biopsy will pick up that immunity. Okay, anyway, that's only a short case, prelude. Now I'll go to the long case.
What treatment did you give her, sir?
Only steroid, IVMP for 3 days, only 3 days. Same road.
Will it recur, sir?
Maybe that's a possibility. Always keep the such a patient to follow up. If it sometimes they can recur, again improve steroid, again recur. If you got recurrent pseudotumor like that, you have to give a long time immunosuppressant like mycophenolate or azathioprine you have to give. Sometimes it may be monophasic. There is an entity called recurrent polyneuritis cranialis, in which one cranial may occur at one time, another cranial may occur at another time, at different places it can occur. Something mimicking a Tolasahan, but it's extending beyond the superior orbital fissure region, can happen the 7th nerve, 10th nerve, and all. And I had a patient who had recurrent like that, he had to put on long-term immunosuppressant. After 2-3 years, no further recurrence. For 10 years, no recurrence now. So how these lesions behave is very erratic. We can't predict which way this patient will go. Okay, now we'll go to the proper case.
Oh, one doubt, sir.
Yeah, please.
Hello.
Yeah, please,
Sir,
please.
do we have to rule out CA breast in this case?
Yes, exactly. That in fact, I forgot to mention. The first thing I saw when we saw this was to do a mammogram in this patient, and that turned out to be negative. Then only we started on the patient steroid.
So why
Okay, sir.
we should rule out carcinoma breast?
That is one of the favored. I do not know why. For CA breast, this is one of the orbital 7 favored site of a secondary.
Okay, thank you.
Okay, right.
Sir, in this case, the diagnosis is only on exclusion, sir, or biopsy
Yeah.
was done?
No, we excluded other conditions like sarcoid and Sjogren's, things excluded, and then we put the patient on steroid.
Okay. Biopsy was not done, sir.
Biopsy was not done. In fact, it would have been ideal if you could have done a biopsy. But anyway, in such patients, no, you can definitely give a trial of steroid. If it's inflammatory pseudotumor, it will immediately respond.
So why does it
Sometimes
exist?
lymphomas.
Pardon?
Sometimes
Why
lymphomas do respond
Yeah,
to
yeah,
steroids,
yeah.
no, sir.
They do, but they will not show such remarkable melting away of the lesion will not occur with lymphoma. They will decrease in size, but this can, especially in the orbital lesions, if you the first priority should be inflammatory pseudotumor. I agree with you. Lymphoma can also respond to steroid. In that case, it will recur after stopping.
So why do they really come?
Pain and she came with proptosis and diplopia only.
Is there any predisposing factors why this comes in people, sir?
Why in the inflammatory pseudotumor?
Yes,
No
sir.
idea. No idea. You often see in young person, young adults, male or female, without any morbid abnormality. Why some people develop, I don't know.
Any
Okay, sir.
association of
Okay.
diabetes in this case,
I'll go to
sir?
the long case.
Association of,
This is a story of a 62-year-old lady. She was treated for carcinoma of breast 5 years back, for which she had undergone surgery followed by chemotherapy. Last dose of chemotherapy was 3 years back. For the last 1 year, she noticed pain, numbness, and tight feeling of both feet up to the ankles. She noticed slowness in walking, as well as loosening of chapters from both feet for the last 1 year. And there was an increasing dose of levodopa, a percentage is syndopa plus 1 tablet QID. For the last 3 months, she noticed worsening difficulty in walking and developed total inability to walk for the last 1 week and became wheelchair bound. So I think I'll show this once again. Carcinoma was treated 5 years back, followed chemotherapy, and the last dose of chemotherapy 3 years back. The present problem started only 1 year back. Pain, numbness, and tight feeling of both feet up to the ankles. Then noticed slowness in walking, as well as loosening of the chapels. And in fact, diagnosed as Parkinson's disease from outside. And gradually the increased doses ended up to 1 tablet QID. For the last 3 months, she noticed worsening in difficulty in walking and developed total inability to walk for the last 1 week and was wheelchair bound. This is a video of the patient. See the tremendous difficulty in pushing her feet forward.
Try. ഇപ്പോൾ നടക്ക് അത് അറിയാൻ വേണ്ടിയിട്ട് മുമ്പോട്ട് വയ്ക്കുക ട്രൈ അതെ ഒന്നര മറ്റേ കാല് ഈ മറ്റേ കാല് അങ്ങനെ ചെയ്ത് മറ്റേ കാലൊന്നും എടുത്ത് ഇടത്തേക്ക് വയ്ക്കാനുള്ള പ്രശ്നം.
Now go to the proper examination. Her caleness are all normal.
ഇവിടെ
Tone was normal in the upper limb.
കൊടുക്കരുത് തിരിച്ചാൽ മതി തല നമ്മൊന്ന് പൊക്കോ പിടിക്കോ ഒന്നും ചെയ്യരുത്.
Deltoid power, neck muscles normal, deltoid normal, posterior muscles are normal. Just got wasting of the introshi, posterior introshi. Biceps power normal, biceps normal. Wrist sections are normal. Finger extensions are also normal. Finger flex is normal bilaterally. Her abductor pollicis is brevis was weak, longus was normal. This is longus is normal, but brevis was weak. Introshi were also weak bilaterally. And she see the finger abduction sign. He's saying that the finger has gone out. The introshi were weak bilaterally. Prominent sign was positive bilaterally. See the classical finger abduction sign on the right side. Present bilaterally more on the right side. So this is the upper limb finding. Now come to the lower limb. Tone appears, even though she's tracking the feet, not much. There's mild suspicious spasticity. He could not lift up the right lower limb, only up to that level, and just go. Both reflexes were weak. Both weak, bilateral, more on those.
എന്നെ ആക്കാൻ കൂടെ സമ്മതിക്കരുത്.
This way also reflection was weak. Knee extension was weak.
ഫോഴ്സ് കൊടുക്ക്.
Both bilaterally weak.
ചവിട്ടിക്കോ.
Hip abduction normal.
അത് തന്നെ അതേപോലെ.
Also adduction was normal.
ഇത് അവസാനിക്കുന്നു.
The hip extension however appeared weak. I could overcome the hip extension bilaterally.
തള്ളമ്മ.
Knee flexion also appeared mildly weak. I could overcome the knee flexion.
അകത്തോട്ട് പിടിക്കമ്മ. അകത്തോട്ട് പിടിക്കേ.
But lower distal muscles are normal power.
Very good.
Quite good
പിടിക്കേ.
power.
മതി. ഈ തള്ളവില് പൊക്കിക്കേ. ഇതും പൊക്കിക്കേ.
That is also good power.
അത് തന്നെ. ഇതും ചവിട്ടിക്കേ. മതി. കഴിഞ്ഞു.
Upper limb processes biceps normally elicited. Supinator also normally elicited. Triceps also normal. Fingerprint did not get bilaterally. Both knee jerks and hand jerks were absent. Mean 3 influence was absent. Ankle jerk were also absent. Plantar was indefinite, but petrol is downgoing, not upgoing. The pain sensation was normal in the upper limb. Distally, it was also normal. All normal throughout. Vibration is normally present. It is absent in both toes. It is absent up to the knee. Normal. Normal. Feet, it is abnormal. It made mistakes bilaterally. Sorry, it was correct on both sides. Vibration is impaired, but joint sense is normal. And the next video, she is made to get down and walk about. The difficulty in getting down the stool and then walk about. Thrombus was negative. This is the way she was. Really cooks to push her feet forward. So on examination, cranials are all normal, motor, upper limbs tone normal, mild wasting of FTA bilaterally, power upper limbs, both deltoid, biceps, triceps, wrist extensions, wrist flexes all normal. Finger flexes, finger extensions, abductor pollicis longus normal. But all small muscles were weak bilaterally, more weak on the right, but there are thenar, hypothenar, introsci, adductor pollicis. And the finger abduction sinus person, both hands more on the right. The lower limbs tone normal when checked at the bedside. Power hip flexes, grade 3 to 3 plus, more weak on the right side. Hip abduction adduction normal. Hip extensions are also weak, grade 4 to 4 plus. Knee extensions weak, 3 plus to 4, more weak on the right side. Knee flexion 4 to 4 plus. Angle dorsiflexion, plantar flexion, EHL, FHL all normal. So in summary, weakness is more on the hip flexes and extensions, knee extensions, knee flexes, all more on the right side. DTR upper limb biceps will be normal bilaterally, triceps 1 plus bilaterally, finger flexion absent. Lower limb knee jack and ankle jack absent bilaterally. Just flicker on the right calf, it may not be significant. Plantar flexor bilaterally. Sensation touch normal in both upper and lower limb. Pain and temperature decreased below mid-shin on both legs. Rest of the area is normal. Vibration normal in the upper limb. In the lower limb, it was impaired over the big toes and over the malleoli bilaterally. GPS sensation, however, is normal in the upper and lower limb. Thrombus is negative. Gait dragging of both feet. Tremendous difficulty in initiating the gait as gait gets stuck to the floor. So this is a story. Any clarification you can ask? Anjana? Plug with the connector. Yes, any clarification?
Sir, was the patient on any cisplatin-based chemotherapy when she got the chemotherapy 3 years ago?
No, chemotherapy was stopped 3 years ago.
Yes, sir. And so she was not on any medication for the breast carcinoma after that.
No. That also stopped 3 years back. Last dose of chemotherapy was 3 years back. The present problem all started 1 year back. As soon as in walking and dragging on the feet.
Sir, from the composite history and the examination, this suggests that there is involvement of both the motor and the large fiber sensory predominantly, with some suggestion of a small fiber involvement as suggested the loss of pain and temperature below the shin. In the upper limbs, it is more restricted to the distal part, the small muscles of the hand. In the lower part, and the lower limbs, it is involving the proximal muscles as well, sir. So,
Yes.
sir, in a patient like this who is having a history of breast carcinoma, already stopped chemotherapy, so there's no question of any drug dependent neuronopathy. So there can be, sir, recurrence of the tumor with a paraneoplastic sensory motor neuronopathy in this patient, which is suggested by the severe ataxia. So it may be a CISMP type of a picture or an atypical CIDP with sensory predominant involvement, lower motor. Although suggestion of myelopathy is little less for this patient because in the lower limbs it is predominantly element type of weakness, sir.
Okay, but where do you consider ganglion neuronopathy? Because see here, her upper limb reflexes are well elicitable. She has good distal muscle weakness. In the lower limb, her only joint sense is normal in the lower limb. Only vibration was impaired, and she's also diabetic. Moreover, rhombus is negative in this patient. And her problem is mainly motor, not sensory. Because the proximal muscle in the lower limb, reflexes, hip extensors are weak, knee flexors and extensors weak. But the upper limb distal muscle is very weak. So it's only motor, sensory is minimal if at all. And that can well be explained by diabetic neuropathy also. The muscle which are up in the upper limb sensations were normal.
Sir, was there any anterior hornswell pattern in the upper limb involvement, sir? There is a differential involvement of the small muscle wasting in the upper limb, sir.
Yeah, I can call. In fact, all the small muscles are affected with sparing of the long interfaces and all. That can go with, not necessarily mean anterior hornswell. To call anterior hornswell, the pattern should be really patchy, not conforming to any root or any nerve distribution. See, for example, if you find one muscle of the ulnar nerve, one muscle of the median nerve, that's a patchy involvement. Here, what happens? The distal involvement can be well explained by the nerve involvement. Median and ulnar involvement distal can explain that thing. Can also be explained by a CAD and root involvement. So that pattern need not necessarily be okay. If you ask me, can it occur? It can occur. But
Sir, but the CAT1, if the CAT1 root is involved, even the extensor indicis propria should be involved, sir. Here the patient has the weakness restricted to the introsea and small muscles of hand, which is supplied by both the median and the ulnar, sir. But which is restricted only to the involvement beyond the wrist, sir.
Yeah,
So,
what I'm saying, if it is
but
a
there is not,
C,
sir.
I'll clarify that point. If it says CAD1 root or segment involvement, the confined muscles affected only may be confined to the small muscles. You can sometimes get weakness of the long flexors also, but they are going to supply from other roots also, it's like the C7. So most likely, as you correctly said, the C8 should involve, long finger flexors also should involve, but need not necessarily be so. Sometimes the involvement of the muscles need not involve all the muscles separated by the root. It may be confined only some muscles separated by the root. For example, in the thoracic outflip syndrome, the only muscle affected may be the thenar muscle. In C8 root, only muscle affected may be the small muscles of the hand, the ulnar nerve distribution. So that pattern can occur. To call anti-console, it should not fit in with either a root or nerve. Then only we can, by the distribution ways, we can call. For example, if suppose somebody comes to you with introsea weakness alone and adductor policies without any hypothenar or thenar muscle weakness, one may think it is anti-console disease. Need not necessarily be. For example,
Deep
deep
ulnar nerve,
can also put it that.
can produce
Can
it.
also put it like that. So that is you have to keep in mind. But if you find a patient with only one interosseous is affected, two interosseous is affected, other interosseous is spared, and one thenar muscle is affected. That pattern is not fitting with the root or a nerve node. That situation, you have to suspect strongly anterior disease. Really patchy involvement.
Polyradiculopathy.
Yeah, polyradiculopathy is a very good possibility. Like the only thing is patients no definite sensory other than the pain loss. If a large five respect post-equilibrium where there is pain. Okay.
Sir, pure
Sir,
motor
can I make
variant.
an attempt? Please.
Sir, it seems like a tough case. So, motor is bilateral distal small muscle with proximal lower limb involvement without any predilection for flexors or extensors. Both are affected, and lower limb distal is spared in the lower limb, and the weakness part looks like a LMN. And the sensory is in the feet, and she's a diabetic. I'm not sure whether I can dissociate this and call it a pure motor syndrome.
Definitely, we can dissociate here.
And localize with if the motor problem LMN with hyporeflexia in the lower limb, and if we consider the sensory in the feet as a distal gradient peripheral neuropathy dissociated from the motor weakness, it could be a myopathy also.
Yeah, it could be myopathy also.
Myopathy involving hand muscles or small muscles of hand is.
No, that is quite odd. Usually, the one condition where you get proximal lower limb and distal upper limb is what? Which myopathy?
Inclusion body myositis.
Yeah. Inclusion body myopathy, it classically affects the long finger flexes.
Long finger flexes.
Or the small muscles. But of course, you can keep that possibility in the back of the mind because we have to keep various possibility in our mind.
And another point that is finding difficult is the disproportionate gait problem. I'm not sure whether we can explain it with the hip flexion and extension weakness, but she has got prominent gait problems, which is slightly odd.
Yeah, that is also very odd. So these days, not a very severe hip flexion weakness, still she's not able to take a lot of effort to push forward. So that's also very odd.
Another possibility is distal symmetrical diabetic neuropathy with diabetic amyotrophy.
That is another possibility, but how do you explain the upper limb distal muscle weakness without sensory? That will become
Sir,
a
in
problem.
upper limb, median small muscles are involved, like APB and thenar muscles. Paired or involved?
Yeah, both are involved. Both thenar, hypothenar are affected. I think this little tough case.
Sir, is there any wasting proportion to the weakness?
There is interosseous FDA is weak. Lower limb weak wasting because it is the thigh region. I am not very sure because I have not understood to that extent to see that thing. There is no obvious wasting. Was there not there?
If there is a significant weakness without much wasting, a demyelinating pathology is likely. Sir.
Yeah, it's a good possibility. Very good possibility. So we are not sure what it is because again, all many points are again is demyelinating pathology affecting the upper limb without sensory and with retained reflex in the upper limb. In the lower limb, you find absent reflexes favor, but she said diabetic. But muscle pattern was not fitting with any root involvement in the lower limb. So could be a radicular neuropathy pattern, is agreed. But then many points.
Was there any fatigability in the weakness? Any fatigability?
No fatigability. Okay, let us see, as you said correctly, what could be motor CADP. Again, anticondylar disease, previously doctor was telling there's a possibility the sensory may be part of his diabetic neuropathy. So even though it is not patchy, that does not mean if all muscles are affected, naturally anticondylar also mimicking neuropathy. Myopathy, inclusion body myopathy, already mentioned one of this possibility. Along with diabetic periphery, these are the possibilities one you have to keep in mind, correct? Okay, then what is causing a gait problem? Well, that is the first thing to occur. Before she became wheelchair bound and she's unable to get up and she was walking with, that is why somebody else diagnosed this as is a Parkinson's disease. That means she must have been having this walking problem for long. So Is it PD? Is it NPH? Is it a progressive mechanism, gait freezing? Whether the abnormality is only something like an EDF, lower body Parkinsonism. Okay, these are the things we have to keep in mind. Okay, what investigation you want now?
Sir, this much weakness, can we explain the gait problem? Because hip flexion is something around 3.
Not
4
3.
minus.
No.
4 minus.
Yeah, 4 minus. Yeah, 4 minus. Okay. So I would say even with 4 minus, they'll be able to walk out. No. See, she's not able to push her level forward. They see the tremendous difficulty she initially noted when pushing her forward is not possible. With gait for power, it's not against cavity. It's against not able to push forward.
Okay.
That's it, Lord.
And there is some asymmetry, sir. Left is more
Yeah,
affected.
right. Left is more dragging compared to the right side. And she did not respond to sleeve Udopa because that we just started earlier. She was in forced in Udopa, just stopped us secondly after admission. And no worsening in head gait. Okay, now let us go for the investigation. What investigation do you want? Whatever you want, I can.
Studies.
Nerve condition studies. Okay. This is a nerve condition study, lower limb. There is some mild decrease in the velocity, not in the demyelinating range in the both common peroneal. Then the median amplitude is very low on the right side, both sides amplitude low, and left ulnar is also amplitude is low. Mild low, not very gross compared to the right side. It is decreased. See, on the right side it is 11.6, left side it is 4.6. Even the clinically, I thought right ulnar was more affected. Here on in electrophysiologically, we found here because it is in the ADM. We picked it up, not from the introsheath. Okay, the velocity was dilators prolonged the median bilaterally. It's not very important because it's a diabetic, maybe have associated carpal tunnel. Here the velocity is 30, 33, and sometimes 35 in the left median. And come to the sensory, apart from the absent sensory in the median now, which could be due to the carpal tunnel, ulnar distribution, lower limb distribution shows normal sensation. So clearly, diabetic neuropathy, if at all is present, is very insignificant to cause any even disability to the patient. May explain some vibration loss in the lower limb, but cannot explain everything.
Maybe for small fiber neuropathy.
Yeah, it could be small fiber neuropathy. It could be if you want to explain the decreased vibration also in the lower limb. Lower limb vibration was absent, but JPS was normal. So it's a large fiber neuropathy. Pain was not affected. Okay, coming to the FA, this is lower limb FA latency is normal. Upper limb is prolonged. This is the pattern on the FA left side. This is on the right tibial, on the right median, right ulnar.
The lower limb FFs are not from the weak muscles.
Because because CMAP is absent, no? You could get a CMAP from the very low amplitude. So FA cannot be concluded from that. We cannot give significance to the absent FA because the CMAP amplitude is very low. I will show that CMAP amplitude of this is only wait. Not CMAP, but it's not very low. 4.3 and 5.4. Okay, yeah, it could be significant. Upper limb also it's not there, it is very low. You are right. That's also can be significant. But that's normal. The lower limb FA is normal.
But in the lower limb, the proximal muscles are weak, sir. The distal muscles have normal power. So the FA may be normal from the tested muscles.
Exactly. So unfortunately, we are not doing FA from the proximal muscles. That's why whether the affected muscle is a prolongation, we cannot judge. But we do know the upper limb distal muscles are affected, that muscles have got prolonged FO. Okay, what do you want to do now?
CPK is not, sir.
Pardon?
CPK?
CPK was normal. And then the other possibility can be an MND by any means.
Can we consider LEMS here? Because proximal lower limb muscle
Yes,
weakness.
LEMS should also be considered.
LEMS can be considered, but I did not consider that possibility.
Because rarely in paraneoplastic LEMS they can present with gait ataxia. But we find a mixed sensory motor pattern. The motor may predominate or the sensory may predominate. Rarely LEMS may present like this with predominant gait abnormality.
Yeah, but this is not the gait abnormality of LEMS anyway. It's not a proximal muscle weakness gait problem. It has got tremendous pushing the forward as if the limbs were very stiff.
Sir, even though there are a lot of points, I would like to have an MRI of the cervical spine as well.
Cervical spine also. Okay, okay. We can keep that possible. Okay,
So
now the
plantar
question.
is flexor or extensor.
Plantar is indefinite. If at all more like a flexor. Can be anterodorsal disease in this patient.
Yes, sir, a typical form.
Yeah, there is no sensory in this patient. In the upper limb affected. The lower limb you can find there is only abnormalities, vibration loss that can be explained by this thing.
Sir,
And
there is the pattern is not patchy. There are no fasciculations.
Yeah, correct. That agreed. Not agreed, very well agreed. But we have to keep any possibilities. Not fitting with anything now. So why not? Somebody asks you why not anticonceptive disease? Because I have abdominal weakness without any sensory, with wasting the hand.
Yes, it is possible.
Yeah, that way you have to keep that possibility in the mind. Somebody also mentioned that possibility. I cannot rule out that possibility. So EMG was done. This is the EMG from the cortices. There is no spontaneous activity. There is mild increased bearing frequency, otherwise normal the left corticeps also in its activity. Mild increased bearing frequency, normal. Then right tibialis anterior. No spontaneous activity. Okay, that is normal. Need from the right FDI. There was a wasting in it. Might decrease in the interference, otherwise normal. Same with right APB. Very occasionally it was there. So aging almost normal, it's a mild decrease in the difference in both, otherwise normal. That may be due to decreased effort on the part of the patient also. Okay, so that reasonably rules out a motor neuron disease. Now, what else do we like to do?
Contrast MRI of the roots.
Okay, right. So MRI LS spine. This is the LS spine. This is the T2 space. Normal. I'll show the other films. Then this is axial plus this thing. corresponding. Again, no thickening on the roots, anything will be seen. MRI lumbar plexus also is taken, that is normal. Then what else you want now?
Contrast study, sir?
Contrast was not done. There's no thickening, no clumping, and electrophysiology also not typical of
CSF.
Sir,
CS.
brain, sir.
Why brain for the gait? Okay, agree. For the gait. Yes. Of course. We forgot about that. So you have two problems now. She has got an element weakness plus a gait problem. Gait problem, don't you tell them. Agreed. For that, the brain isn't good. We'll come to that. I think we'll first sort out the element problem, then we'll go to the gait problem. Okay. And see, I wanted to do CSF, but patient was not very keen doing a CSF.
RNS was done, sir.
RNS was not done. Because I didn't think there's no myasthenia. I did not think it this patient. Because knee jacks were absent. Hand jack absent with muscle weakness.
In LEMS, you can get an absent ankle, can you?
Pardon?
In LEMS,
LEMS can have a absent jack handle like this. But is it the presentation of a LEMS? You can get in a theoretically possible. And she complained.
Sir, can I clarify one point? May not be relevant, but there is some, previously you taught some dissociation in vibration and joint position. There is some localizing value for that. Is it relevant?
Yes. Because, if somebody has got a loss of vibration earlier than the joint position sense, it usually indicates a demyelinating type of pathology. Because for demyelination requires for the vibration sense to pass, you require the fastest conduction.
Okay.
Because vibration is nothing but only touch sensation. But it's a rapid frequency of touch is occurring. So even if a short period should transmit it. If some delay in the transmission of touch, vibration will be lost. It appreciated as only stress sensation. So that's one key point. Not absolute point, 80 point favoring a demyelinating. And previously, people would say in spinal cord disease, posterior column, the joints will be lost early than the vibration. Because vibration can be carried through both posterior column and spinal thalamic tract.
CPK is normal for this patient, sir. CPK?
CPK was normal. In my CPK is normal.
In osteomalacia, can we consider some metabolic myopathy like hypothyroidism, osteomalacia?
Possible. There was usually they put is pain in the limbs. There was hip muscle syndrome. There is no pain. In fact, serum calcium, other things are all normal. That is normal. This ANA profile normal. Root biopsy was also normal. Now what to do now? Somebody was asking what is causing her walking difficulty, which has been there for 1 year. Was it due to proximal muscle weakness or unrelated frontal gait disorder? I thought it's definitely unrelated to the frontal gait disorder.
Brain MRI.
Okay, so brain MRI neurotoxicity, that's the idea today. NBA. Brain MRI did not show any abnormality. Normal. No NPH.
Sir, I would like to have C-spine MRI.
Why C-spine MRI? Because it's clearly lower limb spines are all element, no? There is no human.
Yes, sir. But there seems to be there's like a motor level at distal only affected, but there are several odd points. Still, I would like to have.
No, I did not do an MRI. It means whether done or not. I think I don't have because I didn't think.
Yes, sir. That is correct. That is it. There is no human in the only.
Yeah, definitely human is not there. There is difficulty doing MR in brain for a reason for the walking difficulty. So this is follow-up after 6 days. Walking difficulty, mild improvement, very, very questionable improvement. Not much improvement at all. But her muscle power is improved. I'll show the muscle I'll go to the 11 positive pending only. See the in the small muscles, picked up the power. Much better than before. They can easily overcome previously. It is much better now. See the intro again. She could not initially open this thing. Now she could open it very easily. Now come to the lower limb power. See, she was able to lift up to 90 degrees with the power. See the job. She was not able initially you remove the picture. With one finger I could bring it down. Again, it is much better now. Power was remarkably able to become 4. See the knee extension, very good power. Now great difficulty in overcome that thing. Hip extension also slightly better than before. See the knee jerk has come up now. Did you see the knee jerk? I will show the knee jerk once again. See the knee jerk, which was absent earlier. See, it has come up. That's also come up. And knee jerk also just sensitive. Just sensitive. There is no kinesia or anything in the feet. But the gait problem did not much improve. She still has got that dragging of the feet and then some kind of stationary gait. So in gait remains almost the same. Power, but power of the intro is improved. Lower limb power reflexes cortices is improved remarkably. And no features of Parkinsonism. Now both knee jerk, which is absent earlier, has come back. In fact, what was the treatment given? Methotrexate for 5 days only. And see the NCS changes as has come up now. Now, these values are all normal. I will show them. This is sensitive again remain the same. See the FA now, which was prolonged earlier, has become normal. Will come down now. I'll show the comparison. This is the previous NCS study in the upper limb. This is a recent one. See, it was in the left median. It was initially 30, now it has become 40. The remarkable changes in the FA. See, this is FA with the upper limb H1 before. Always quite prolonged, 42, 30, 36, 37. Now this is the FA with the upper limb now. 30, I'll show the comparison. See, the upper one is the old one, lower one is the lower one. Except the left median, median ulnar, it has been almost the normal range. It is remarkably improved compared to the right median is 42, it has come down to 35.
And the lower limbs have increased.
The lower limb could not be got. No, it was absent initially because the lower limb affair. Sorry. So I'll show that. Lower limb affair was normal initially also. We discussed that. Yeah, previously also it was normal because the lower distal muscles were not affected in this patient, the lower limb. It was the postural muscles affected in the lower limb. The upper limb distal muscles affected, lower limb postural muscles were affected. That will be discussed earlier. Why they favor
in the repeat study, sir. In the repeat study, it shows the increase in FA in the lower limb.
Repeat study, let me see that thing. Just 1 minute. I only showed the upper limb, lower limb. I did not copy it over here. Anyway, I'll come to that. Is this a previous? It is on here.
Next
This is the
page,
previous.
sir.
This is
Next
the
slide.
previous FA. Previous FA on the upper part. Again,
Yes, and the piece here, it is increased, sir. This
FA is increased here in this recent FA. Contrary to what you find the other thing. That we expect.
so is it the CIMP?
No, okay, you can call it CAMB without a sensory. Nobody can say no, or it could be simple terms. You can call it motor CADP.
Because
Sir,
the
if the
distal conduction
reflex
is
loss was because of the diabetes previously, the return of the reflexes suggests that there was probable sensory involvement which has now improved after treatment. Even though the Romberg was negative and everything, but the reflexes has returned, sir.
Correct.
So
Yes,
it may be a GB syndrome like of a presentation which improved with steroids, element type of nodopathy or something like that, sir.
That's exactly what I'm trying to say, that what the patient must have had, a demyelinating type of radical neuropathy. Whether it is the root or not, nobody can say. Okay. See, that's why in GPS, the lesion can be not necessarily be confined to peripheral nerve. It can be in the root confined root cell. There we call it as CAS, and then somebody pointed out that point. It will be CAMB. But
so
you
the
cannot.
prolongation of the distal latency and when compared to the FA, the distal part is much more preserved compared to the roots. So it could be more in the favor of a CIMP.
Yeah, that part is agreed. That part is agreed. But that's only applicable only with the involvement in the distal segment. If anywhere in the proximal, see, it may be anywhere in the proximal to the proximal stimulation can prolong that thing. It not necessarily be in the roots.
Essentially, CADP being a non-lung dependent neuropathy, it need not be root. It may be like sir pointed out, proximal segments.
For example,
there is no gradient.
For example, if you take the lower limb muscles in the here, this patient postural muscle weakness. Okay. And the demyelination may be in the femoral nerve, maybe in the gluteal nerves. That may improve. Need not necessarily be in the root. See that the very point of calling radical neuropathy is a big question. Because suppose if somebody has got proximal distal muscle weak lower limb, how can we ever say it is a root involvement? Because nerve root ultimately gives to the nerve. So nerve involvement, root involvement produces the same weakness.
If there is CSF protein elevation, then we can say it is a root involvement.
Yeah, correct. That's a different thing. Clinically, you cannot say. Since it's a motor nerve sensory, you can say you can differentiate pre and post ganglionic. But here there is no ganglion, only anticonsal there. That is cell body. So lesion anywhere distal to the anticonsal, be it on the root, be it on the nerve, be it in the plexus, all will produce the same NCS abnormality, decreased amplitude. If demyelination is occurring, which the site of demyelination determines the abnormality in the finding. Very stimulating.
If you do a contrast study in such cases, will it be more useful? Because
we could do that. You're right. If it's a contrast enhancement, you can go to that. You can find it. But when you without any nerve thickening, you may not find a contrast enhancement.
Even if you get some contrast enhanced root thickening, will it rule out CADP? It is also well described with CADP as well, sir. Root.
Look, what you are saying, it has an added point favoring a CADP.
Yes.
Root involvement. That means the roots are also affected.
I'm saying whether that point can be taken as a differentiating point between CAMB versus CADP, because both can have.
Yeah, that cannot differentiate.
Yes.
That cannot differentiate. No, that cannot differentiate. Even ordinary GBS also you can have involvement of the root also. That is the CSF protein also elevated. Okay. Now this is a repeat in FA studies. Also there is changes there. This is the previous FA. This is a recent FA. More waves has come now compared to the previous one. This is again the recent one compared to the previous one. FA persistence also is improved. So CADP cause over gait abnormality. Now the question comes back to the point. What is causing gait involvement? Even the muscle power is improved to grade 4 to 5, nearly 5. Her gait is not improved.
So the lower limb snaps were normal in the patient in the previous NCS and the current NCS. The lower limb sensation.
Both are normal.
So SSCP was not done, no?
SSCP was not
lower
done.
limb SSCP. Okay.
We could do it if there is a lesion suspected to the proximal to the ganglion, we can do that. But sensations are normal. So that's not going to help us much. Value comes the sensory sensations are lost. So for example, JPS sensation is lost. And you find the lesion for the sensory loss, then you can do that thing. It's not whether it's in the root or in the peripheral to the ganglion, you could do that.
Sir, any history of REM sleep behavioral disorder, sir?
Sensory?
REM sleep, RBD, sir.
No, in fact, that's a good question. There was no RBD. Because that's one, say, if you look at the kid, it's like a Parkinsonism. Her face does not fit in with any Parkinson features. No achenesis in the upper limb, no achenesis in the lower limb. In the bed itself, she can move the upper, move the toes and so feet up in a very beautifully well. But only the point is walking difficult. So what condition will you think? NPH is not there.
Glon 5 is one possibility, sir.
Glon 5 with only gait abnormality like this. So this condition is called progressive akinesia gait failure. They present only with something like lower body Parkinsonism, gait freezing, but no features of Parkinsonism. It's type of a PSP variant where they convey only to the lower limb. If you ask
follow up, on follow up
only follow up can tell, correct. So that's only the diagnosis. Suppose you diagnose of upper limb Parkinsonism later on, it becomes a PD. But such a severe gait akinesia with no features of Parkinsonism and no response to levodopa, thinking that Parkinsonism is less likely. That's what I think. Now, these after follow 2 weeks later again. So I think I'll show skip all the just only the positive findings I will show. Much improved better now. I think I'll show only positive. See the power is much better now. This again. This is after 2 weeks. The lower limb. Lower limb is also better compared to the previous. Anyway, in the interest time, we'll skip all these things. The power of all small muscles became better except for the fourth palmar intrusion. That just did not improve. Lower limb power is from 3 plus to 4 to 4 plus. Lower limb knee jack 1 plus on the right side. Both angles 1 plus. So that's the story of the patient. Okay. Why these cases brought us 2 things. One, the gait abnormality was difficult to explain. Second, the presentation of distal upper limb, proximal lower limb weakness in a CADP presentation, that to pure motor CADP. So always keep the condition in the back of the mind.
Pure CIDP, motor CIDP usually worsens with the steroids.
Pardon?
Pure motor CIDP usually worsens with this, gets worse with the IV immediate muscle.
But who said like that? Nothing. They can also improve just like the GPS. Even I think, I don't know whether you have shown one patient 15 years duration of CADP and with 5 doses of IM, started walking. That lady from Ernakulam, I think even I can show the lady. They can definitely improve.
Pure motor, sir. Pure motor type.
Pure motor type also, they can improve. I think I'll show that case next week.
Sir, one doubt. Sir, this primary freezing of gait kind of presentation.
Just one before. The one which do not improve is the CIAN type. There is a chronic inflammatory axonal neuropathy, not CADP. DP means demyelinating type. They improve. There is a similar condition called CAAN, chronic inflammatory axonal neuropathy. That is poor prognosis. Yeah, please ask question. Carry on, please.
That primary freezing of gait kind of presentation is always confusing at the bedside, for me at least. Like, can we reasonably exclude this bilateral hip osteoarthritis without much pain and all? Does it come as a differential? Like,
definitely, it should come as a differential. Okay. See, when the patient has got a difficulty in walking like this, some people with hip fracture also, they will walk like this. Okay. But at the bedside examination, we'll exclude when you move the hip and all, you can find it out. The walking
without much pain, sometimes people have...
you are right. Sometimes they may not have pain at all. But there's a chronic distal fracture, they may not have pain at all. But on examination, you will get the pain when doing the pattern test and all.
Okay. And osteoarthritis, knee and hip osteoarthritis with degenerative changes.
They walk like this, yes.
Okay. Okay. Thank you.
Yeah. Okay, shall I go to another case?
Yes, sir.
Yeah, right. Now, this is a story of a 26-year-old lady. She underwent cesarean section 3 days back. On the second day, when she recovered from the spinal anesthesia, she noticed numbness of both lower limbs below the inguinal region and difficulty in walking. That's only complaint. Now look at the patient's video. Power of the upper limb normal. Lower limb tone was normal. Power is also almost. My reflection weak. I'm not sure that she's trying to put it in the immediately postpartum. So, distal muscles normal, EHL normal. All muscles are normal. The reflexes are well elicited in both upper and lower limb. We cannot just call it brisk, maybe normal for her. Lower limb also well elicitable reflexes. Plantar was mute. Oh, sorry, maybe indefinite. Not either up going or down going. Sensation touch was normal. But pain sensation. There's a level of pain in the region. It's more sharp in the upper limb than the lower limb. There it is normal. Decreased on that area. There it is decreased. That's the area where she feels the pain. Same on the left side. That's the area where she feels. That I know. He was difficult to explain except for postpartum. Vibration normal in the upper limb. Vibration is normal. Johnson's normal in the upper limb, but impaired in the lower limb.
Yes, impaired.
That's also impaired. Not able to see. There is decrease in the temperature sensation in the right lower, both the lower limb compared to the upper limb. Sorry, on the right lower limb it decreased, left lower limb normal. Thrombus is negative. She walks cautiously. So findings, Taylor's tone normal, motor upper limbs tone normal, power normal, lower limb tone normal when checked at the bedside. However, weakness of both reflex, that's Korea, I'm not very sure, because she was in the middle postpartum period. Other muscles were all normal. Then DTR, upper limbs all normal, lower limb, knee check normal, knee check normal, abdominal reflex absent, plantar flexor bilaterally. Sensations, touch normal in the upper and lower limb. Parent temperature decreased below digital bilaterally, rest of the area is normal. Impaired temperature below inguinal region up to the right toes, up to the toes on the right side. Vibration normal in the upper and lower limb. Upper limb normal, JPS is impaired over both toes. So this is the story of the patient. Findings. Thrombus might be positive, gait mild, that's not very definite about it. So where is the localization?
Thoracic code.
Yeah, so myelopathy, correct. But it's curiously affecting only the pain sensory tracts.
Patchy myelitis or ischemia.
Ischemia, okay. Ischemia due to what?
So post-traumatic
History of hypotension during the CS.
nitric
No,
oxide.
hypotension. Pardon?
Nitrous oxide toxicity can also have this type of posterolateral cord syndrome, sir.
That can be posterolateral cord syndrome. That's posterior column and pyramidal
Posterior column is
So here the spinal thalamic is affected here.
Some delayed
Fail.
effect of intrathecal bupivacaine or something.
Yes. Okay. Okay, let us see this one. So what you want? What do you want?
MRI.
Let us see the MRI. Okay, see the MRI now. Cervical spine normal. Dorsal spine. Grossly normal, no? I'll show the abnormality later. Not much
Diffusion cuts. Sir.
The cord diffusion is not going to help us much at all. Anytime it is various values.
Okay.
Yeah. It's not fitting with the vascular territory either. Now, did you find something here in the space sequence? Did you find something? Hyperintensity.
There is an hyperintensity in the anterior cord.
Yeah, right. The long extensive cord. I'll come to that. Now come to the dorsal axial.
The preservation of the posterior cord sensations and the involvement of spinal thalamic and motor indicates anterospinal artery vascular distribution. Sir.
In the anterospinal artery, classically posterior column should be spared.
Here it is spared, sir.
Here it is affected. Joint sense is affected both the lower limb.
Toxic myelopathy.
But you are right in one sense. You need not necessarily if you think of ischemic myelopathy, we need not necessarily with anterospinal artery. Sometimes radicular artery involvement can produce a posterior column also. Once
Toxic myelopathy.
Yeah, toxic myelopathy. That's what somebody was telling. Bupivacaine-induced anesthetic agent producing toxic myelopathy. Okay, T1 SAG is not going to help us much. I'll show that this T1 lumbar normal. Now let's see the area.
AV malformation, sir. AV malformation, sir.
There is no fluid here in this vision. Not seen that. Abnormal muscles or anything. Now I'll show the abnormality. So I think this is the. You look at the axial cord now very clearly. If you adjust the window width, you can see the hyperintensity within the cord there.
Yes.
Yeah. There is a long hyperintensity you can see in the cord. Also the size you can also later on. That is hyperintensity. See, this is the axial cut in hyperintensity. Sorry, the sagittal cut, long extensive hyperintensity, and in the axial cut.
Is
Okay,
there any
what is
outside pattern? Outside pattern, sir?
there is some suggestion, but not because it's extending beyond that area. Not only confined to the anterior column. So the hyperintensity is seen in the posterior column and posterior and the lateral column. What is likely diagnosed in this patient? And she improved up after a period of time without any treatment.
Ischemic or toxic?
Yeah, not ischemia. It's not fitting with ischemia.
Toxic.
Yeah, okay, let us see. So this is supposed to be weekend dorsal myelopathy. Okay, I'll show one case, then you will understand a little better. This is a story of how much time is there left for me? I cannot take any words. How much time is there?
No problem, sir. 10:42, 10:42. 9:42.
9:40. I think in that case we'll do it next week. I have no problem. Only thing is it's already 9:40 now. This will take another half an hour or more. It was my mistake. I started late. So I think
the thing is the onset of the symptoms. Because onset of symptoms in such a short period is more in favor of toxic.
Exactly. This immediately following spinal anesthesia for patient develop these symptoms. Next day when the doctor gave the round plate, she has been numbness. She's perfectly prior to or normal prior to that.
Is it due to the prolonged anesthetic effect of the drug or due to some?
In fact, I'll explain it in detail later on. We do not know. In fact, the next case will be more exemplifies that particular point which you are referring to. There is some reaction to the drug which causes a demyelination inside the cord, and specifically is a tendency to have the spinothalamic tract more than the other tracts. In this case, next case I'm going to do next week. I'll clarify that issue. All along, this has been reported many times. People were attributing to spinal needle traumatizing the spinal cord and all. Because this lesion is kind of much above that. This is not due to spinal needle causing the damage.
So bupivacaine can have many problems. Previously, I presented a case in CAN which produced a status epilepticus, refractory status. Yes.
Right.
So what was the treatment given, sir?
In the second patient, the patient which are present, no treatment was given. She improved after a period of time. It all depends upon the degree of damage. I'll show you next case. Next week I'll show a case that I'll show in detail. That's also a good case for discussion also in terms of localization. Okay then. Shall we close? We'll meet next week.
Thank you, sir.
Thank you, sir. Good night. Good night, sir.
Thank you, sir. Thank you, sir.
Thank you very much. Good night. Good night. Good night.